So why GI? Why in the world are we going to talk about that at GAPNA? So our GI system is affected by aging. As we age, things change. Motility changes, absorption, nutrition, of course, medications, and then metabolism. And then we all know the whole long list of medications to watch out for with older adults, and then also side effects that affect the GI system. There's also those age-associated reserves that happen as we get older. And just because you're older and you have an older age does not mean you're frail, but we do know that our body is slowly changing as we get older, those pathophysiological processes, and that just leads to more vulnerability. So I'm going to literally go from top to bottom. That's supposed to be a joke, like the bottom. We're going to talk first about dysphagia and odynophagia. I feel like I've got dysphagia myself right now. That's why I didn't drink that water when you finished. I was like, ooh, I'm going to just have a little issue. So with the older adult, with dysphagia, they'll come in saying, I feel like something's sticking right here, and that clues you into the esophageal component. So mainly you have that esophageal and the oropharyngeal component. They'll say multiple swallows having to get things down, and I'll ask them, hey, do you have a problem with chicken? Does it feel like it gets stuck? And they're like, how did you know? And I'm like, because I've done this before. And then it's the bread, the rice, those are those big things that they say that are getting stuck there in the esophagus. The oropharyngeal component, which we know this is kind of a review, is that difficulty initiating that swallow. And then also they'll say, I cough when I swallow, or I drink some coffee and it just came out my nose, and that clues you into that oropharyngeal component. So those etiologies that we know in the back of our mind and we keep on those differentials would be like strictures due to chronic esophagitis, where that esophagus is narrowing down, scarring down, tumors, that's always in the back of my mind. It's not uncommon to set somebody up for an endoscopy and see a big old mass there. You can even have extrinsic compression from outside the esophagus that can cause that dysphagia. And then the eosinophilic esophagitis and Candida esophagitis would be your esophageal components. For oropharyngeal, we know all these things, stroke, MS, Parkinson's, pharyngeal cancer. I have a little story to tell you because this was really interesting. I had a gentleman, he was about 65, that had an endoscopy done at an outside facility, a little north of us, and he had it done because of dysphagia. And this is weird, but apparently his jaw was dislocated after the endoscopy, which I don't know how that happened, but that wasn't appropriate. So he went to the emergency room, had scans, had it all checked out, and he was still having dysphagia. And so he comes to see me because his primary care said, okay, let's get a second opinion. So I see him, and of course I have no records because that's how it goes, right? So I'm an outpatient, and I think, oh great. So I had to get all the records, and I looked at the endoscopy, and there was no web, no stricture, no dilation was performed. Everything looked normal. CT of his neck was done by the outside facility. That was normal. Barium swallow was done. That was normal. And I thought, well, gosh, what am I supposed to do? Because doing an endoscopy was not gonna, help. So I said, okay, let's send you to speech pathology. And his wife called several weeks later, while we're trying to get all this set up, and she says his mouth is just pooling with secretions, like he's having incredible difficulty. The left side of his neck hurts. And I said, okay, you need to go to the emergency room. Something's like desperately wrong. I know I'm all over the place because it's slowly coming back to me because it was such a mess when it happened. There's all these different pieces at the same time. He had seen a head and neck surgeon. I referred him to ENT all during this process, and nobody had found anything. So I said, okay, you need to go to the emergency room because I don't know, this is outside my scope, literally outside my scope. I can't figure this out. I just came up with that on my own. That wasn't part of the plan. But he went to Chapel Hill and saw a head and neck surgeon there, and he had a cancer of the pharynx. And so I thought, gosh, he had already seen a different ENT, another head and neck surgeon, and then sent to GI because they were like, oh, dysphagia, it's got to be esophageal. So that just goes to show you that, just thinking outside the box. And when things are not adding up, to just start digging advocate for your patients. Okay, so odynophagia, that painful swallowing, older adults, they need that higher stimulus for pain. So by the time they present to you, it might be too far along the way. I mean, you can still treat it, but the symptoms have been going on for a long time. So there's that delay in diagnosis. So the first thing I always think of when there's an acute painful swallowing is Candida esophagitis. It's just like classic textbook. Also, we see HSV and CMV malignancy. That's another big one. And then you have that pill-induced esophagitis or reflux-induced esophagitis. With the pills, you've got your doxycycline, your captopril, your NSAIDs, your Fosamax. Ooh, I might be missing some, but there's some big ones there that are notorious for that pill-induced esophagitis. And then, of course, you have your radiation-induced esophagitis. So how do we manage dysphagia? Well, if they're able to undergo an endoscopy, that's number one on the list. You want to directly visualize that esophagus and do biopsies there, because the eosinophilic esophagitis, you're not going to see that just with your naked eye. With Candida, you might see some plaques there on the esophagus, but we've had some where it's kind of like, I don't know, do they have that or not? And we'll biopsy, and the KOH prep is positive, so you treat them for Candida. We have some patients that just are, they're really frail. They can't undergo anesthesia. So the next best thing would be the barium swallow or a barium pill esophagram. And that helps a lot. Sometimes you'll catch they're squirting stuff up their nose. The barium is not going down. And you can see some motility issues also with that esophagus. Speech pathology is my very favorite friend in the world. I have them in my phone. I text them all the time because they can help with those chin tuck maneuvers and different diets that help. It's rare that we do pH and manometries, but we will still do those. And the pH is measuring the acid in that esophagus and how many episodes you're having. And then the manometry is that contraction of the esophagus, the pressure of that lower esophageal sphincter. So, of course, you're going to treat the source with your PPI, your antivirals, your antifungals. Tube feedings, that's another one that we kind of steer clear of, but we did have a patient in the hospital a few weeks ago. I have a colleague here on the second row. She had achalasia, and she was not I believe she might have already had Botox injections. I can't remember the whole story, but I know she was not a candidate for surgery. So her family wanted everything done, so she ended up getting referred for a PEG tube. The Botox injections for achalasia it's pretty, I always laugh because I think of Botox. I tell the doctor, I'm like, can you save a little vial for me when you pull it up? And they're like, okay, fine. So, I don't use it like that, but it just always cracks me up because it's doing the same thing as if you get it in your forehead. So it's relaxing those muscles there in the lower esophageal sphincter. So we're moving on down to peptic ulcer disease. So with older adults, they always present atypically, right? Like the majority of the time with different things. So if they've had a perforation, there may not be those signs of peritonitis, and they may not even have pain. A lot of times with peptic ulcer disease, they come in and they're already bleeding, and you're like, oh, I know what that is. So they don't have the pain, they don't have the nausea. It's just kind of they show up and you do a procedure and you see that they do have those ulcers there. Now, gastric ulcers will be more prevalent in the older women, and then duodenal ulcers in men. That's just a little tidbit. And those etiologies we already know, NSAIDs being the most common. H. pylori is pretty common as well. Cameron ulcers, we do see that a lot with the large hiatal hernias, where that diaphragm is kind of pressing up at that stomach and it's causing the ulcerations on the inside of the stomach. And then those medications like Fosamax, potassium, chemo, those can contribute. And then you could have idiopathic. Of course, this is not exhaustive. These are some of the main ones.